I think we are ready to go. Thanks.
Okay. Good morning, good afternoon, everyone. Thank you for joining us for this webinar on the Vaccine Outreach and Counseling Program. I'm here with my colleagues from the health department and also with colleagues from the health plans who have been working very hard over the last couple of months to put the vaccine outreach and counseling program in place. I'm going to refer to it as the VOCP throughout the presentation. We'll go through what the program is about, and then we'll have ample time for questions and answers. Next slide, please. So many people have questions and concerns about COVID-19 vaccines, and they may want to speak to a healthcare provider about getting vaccinated. So that's why the health department has partnered with some of the Medicaid and Medicare Advantage plans to compensate providers to do a proactive outreach to their unvaccinated patients, counsel them about the importance of vaccination, and arrange for a vaccine for them. And this is specifically for people who has not received any doses of the vaccine right now. So we are focusing on the population that really is in that last stretch that we need to get everyone to be vaccinated in New York City. Next slide, please. The program is reimbursing practices to do this proactive outreach for vaccination. And the way how we are reimbursing is that if the counseling is done by a clinician, then or if maybe the initial call was done by a non-clinician, but a clinician spends at least 3 minutes of counseling in that call, we will reimburse $50. And then if the counseling is done by a non-clinician, then we will reimburse $25. In the case of non-clinicians, they need to be using a script that is approved by the clinician. Once all of the necessary steps have been completed, providers can bill for a complete counseling session. The health plans, they all had various start dates. The majority of them started in October, and the program will run until the end of November of 2021 for all of the plans. But most of the plans are actually planning to extend until the end of December for the program. So it's very important that as providers get notified about by their plans, about who are their patient lists, that they pay attention to what is the end date of the program that has been included by their health plan. Next, please. So we have Emblem Health, Health First, Health Plus, Metroplus, and AmeriCare started the program in October. And we will have starting shortly Centene, Fidelis, and United Healthcare. Next, please. In order to be reimbursed or for the encounter to be billable, there need to be 3 steps that are completed. One is the patient needs to confirm, the provider needs to confirm patient eligibility. So you may receive a list from it's called an unvaccinated list from your health plan. And by the time that you call the patient, you need to confirm that the patient is indeed unvaccinated. Step 2 is to deliver a complete counseling session, and we will go through the details of what that means. And step 3 is to complete the documentation of this counseling in the patient record. Next, please. There are 3 things that we are encouraging to do in terms of confirmation of eligibility, and my apologies about the formatting in this slide. The first one is to review that you need to review the unvaccinated patient list that the health plan provided to you. If a person is your patient but they're not in that list, they're not eligible for a billable counseling session. The second thing is to reach out to eligible patients in the unvaccinated list. So once you have that list, we are expecting that for the program, there will be proactive outreach, primarily phone calls, to the patients who are in those lists. And it's very important that, that this outreach happens, because if a patient is already in your office for a different type of appointment, there cannot be billing for the VOCP program. So the VOCP program is only billable as a standalone encounter, right? So primarily a phone call to a patient who is in your list. Then the last thing is that you should confirm with the patient that they're unvaccinated. This means that they have not received any dose of a COVID-19 vaccine authorized or approved by the FDA, or who are not fully vaccinated with a vaccine authorized for emergency use by WHO. And we know that many patients may state to you that they are vaccinated. The patient's statement should be taken as correct, even if they're not appearing in the CIR as vaccinated. Next slide. Once a patient has confirmed to you that they're unvaccinated, and this means that they have not received any dose of the vaccine, the provider or the designee can proceed to deliver a complete counseling session, and this is a 3-minute conversation with the patient during which the provider or the designee must do all of the following. They should make a strong recommendation for COVID vaccination. In the very, very rare case that it is medically contraindicated, then this shouldn't happen and the patient is not eligible for billable counseling. The second thing that should be done is that they should counsel the patient on the safety and the effectiveness of the COVID-19 vaccines, consistent with the New York City Department of Health guidance, and respond to questions they may have. And then they should arrange for vaccination. And I want to make the clarification that many of the patients that you counsel may not agree to vaccination on the spot. If they do, great. Please bring them to your office for vaccination or help them enroll in at-home vaccination or to walk into a nearby pharmacy. But if they're not ready to be vaccinated by the end of the counseling session with you, that is fine. You would complete this requirement by informing the patient about how they can obtain a vaccine at a later time. Next, please. And then once you complete the counseling session, the provider or the designee must document in the medical record. So you must document the name of the provider or the designee who performed the complete counseling session and the time at when this counseling happened, how the counseling session was performed. So this is primarily going to be a telephonic encounter. The content of the counseling session that shows that the conversation included information on vaccine safety and effectiveness, and the content of the counseling session that shows that the patient was provided with information about how and where to get vaccinated, and that if they were interested in getting vaccinated, that they received assistance for that vaccination. So we're hoping that many of you are choosing to vaccinate in your own provider office, and that way you can invite them to come to the office for vaccination and other services. Next, please. We have created a provider toolkit that is in our website in newyorkcity.gov/health. You click on COVID, then on information for providers, and then on vaccines, and you're going to see the toolkit there. And it includes a bunch of information about the rollout of the program, and I'll go through the content in a second. Next, please. So in that toolkit, you're going to have a program overview. You're going to see the frequently asked questions about the program in 3 categories: the patient eligibility, compensation for the service, and documentation and reporting. And you will also see a non-clinician script. Of course, clinicians who want to use a script can also use that. We also have a voicemail script in case that the patient didn't pick up the phone. And we have information about how to introduce yourself, what vaccine information to provide, and how to provide options for the patients about vaccine scheduling, as well as other resources. Next, please. When a non-clinical team member conducts a vaccination outreach and counseling session, they must use a script that has been approved by the provider. We know that writing a script is a lot of work, so we have written a script that is in the toolkit, and the providers who receive the list and are accountable for the patients should sign off on that script. The script contents include vaccine information, and for vaccine scheduling, we're putting details about how to do an on-site appointment, how to make a home appointment or an off-site appointment, as well as options for patients who do not want to schedule appointment on the phone or who are not ready to commit to be vaccinated. And then in the closing, just reminders about the importance of wearing face covers. Next, please. So what we are presenting here is an example of the revenue and is a conservative example of revenue in the event that you receive a list of 100 unvaccinated people. So let's say that you receive a list of 100 unvaccinated people and that you reach out to these 100 patients. And for some reason, you are unable to establish contact with 70% of those, which is, I think is, we don't expect that number to be that high, but let's assume that is that high just for purposes of this example. Let's say that of the 30 that you are able to speak to, 10 tell you that they're already vaccinated, and 20, you actually are able to do the counseling. So if you assign a person to do these phone calls in your office, and the person spends about 5 minutes per call for all of those who are accepting to be counseled, 2 minutes per call to all of those who are saying that they're unvaccinated, and a minute per call for the people with whom you're unable to establish contact, you will have invested 190 minutes in that target list. Depending on whether the person that was doing the counseling was a clinician or a non-clinician, you would be able to bill between $500 if the counseling of these 20 people was done by a non-clinician, or $1,000 if the counseling of these folks was done by a clinician. So at the end of the day, you will have a revenue of about $158 to $316. Even only reaching 10% of the 100 people list that was given to you. So this is an example. We have heard that some of the practices that started implementing early the program were reaching about 25% of the patients, not reaching, were able to actually counsel 25% of the people in the list. And I want to stress this number because it's important that you don't get discouraged when you hear, when you are not able to speak to many of the people on the list, or maybe when people in the list who are supposed to be unvaccinated tell you that they're vaccinated. All of this information is information that we had in mind as we developed the program and the rates of the program, so that they were generous enough to compensate for some of the work on the people that you're not going to be able to bill for when you are actually able to counsel at least 1 in 5 of your patients. Next slide, please. So when we did the first webinar about the VOCP back in September, when we just launched, there were a lot of unknowns, and now we are at a point where we have most of the plans already up and going with the process. So we have 8 plans, 7 health organizations that are participating. The majority of the health plans are using a claims-based reimbursement, and Metroplus is using encounter-based reimbursement. Each of the plans is using different billing codes, and those billing codes are going to you at the same time that the health plan is sending you or your organization the list of patients who are eligible for counseling. It goes with the billing codes that need to be used for when the counseling session is completed. Here we are summarizing the billing codes that are being used by all the health plans. And we also are keeping this information updated in the New York City Reach.org COVID-19 website, so that whenever information changes or if any plans join the effort, we will be updating the information there. The bulk of the plans are distributing the list to providers the same way that they distribute lists for gaps in care reports for other quality metrics. So in many cases, this means that the lists have gone from the health plan to the practice or the IPA, in an encrypted email. And then in a couple cases, we are seeing that the lists are being posted in the provider portal or in the Quality app. In the case of Health First, they are being posted in the Quality app under measure name COVID vaccine. In the case of Metroplus, they are included in the monthly gaps in care report, and they are in the measure COVID vaccination counseling. Each of the health plans has also established a way so that if you are a provider that typically has a lot of clients with that plan, you are the primary care provider assigned to the members in that plan, that you can obtain a list if you have not if you have not received one proactively. So for the most part, all of the plans are asking you to talk to your plan representative to request that list. And in a couple cases, we have specific email addresses that are listed here, and you're going to have a copy of the slides with the person or a non-person mailbox that would be able to respond to your questions if you want to have a list and have not been able to obtain one. If you are working with one of the New York City REACH specialists of the health department, you can also talk to them, and we will be happy to troubleshoot access to a list or tell you why, if it's going to be possible to get you a list for this program from a specific health plan. Next slide, please. So the last slide had 4 plans. This slide has the other 3 plans that are working with us. AmidaCare is also claims-based, and they have sent a list via encrypted email the same way that Emblem and Health Plus have done it. And Nicole Piscatelli is the person who you can reach out to if you have not received an AmidaCare list and are interested in one. United Healthcare is sending the list via encrypted email. They're starting this week or next, and they are going to be sending lists only to providers that have a sizable volume of unvaccinated patients. So if you suspect that you have a very sizable volume of unvaccinated patients and you have not received the list by the end of next week, please contact your contract manager. We will be adding details about Centene, which is planning to roll out by the end of next week. And they will be including the information about billing in the letters that they send to their providers, and we will also update it in the New York City REACH website. It's important to just highlight that each of the health plans has a slightly different billing code. For the most part, all of them, you just submit the claim the same way that you would submit any other claim. But please be mindful of the billing codes that need to be used for each plan. And in the case of a Metroplus, please follow the instructions that they are giving providers, because it is an encounter-based type of billing. Next slide, please. So I'll hand these to my colleague, Matt Gannon, who has been enlisting all of the New York City REACH specialists to support primary care practices across the city for implementation of the program. Matt?
Thanks, Anna. So our team at NYC REACH at the health department has been meeting with a variety of providers and health centers and hospital teams to work through any workflow issues as they stand up their outreach programs. So I just wanted to share a couple of lessons learned and best practices and early successes from the folks who've been working on this already, roughly in the order that we recommend approaching if you're looking to set up a vaccine outreach program of your own, or expand what you've got going. I think that the first, and it's something that everybody brings up as a barrier, and we acknowledge that staff time is very tight. We're very glad for the opportunity to provide some funding for the clinician and non-clinician outreach that we hope can make it possible to keep somebody on for a few extra hours a day, or to bring in a temp, or have somebody who's part-time come in a couple of extra hours to kind of spearhead these calls and outreach on behalf of your practices for your unvaccinated patients. So the who is a big thing. take a look at the script Anna mentioned, and we'll make sure that everybody has the link. There is a script that New York City has drafted that non-clinicians can use to have talking points and language for their vaccine outreach. It's pretty good, and you can take it and make some tweaks to make it fit what you think would be best for your patients and your staff. Following that, you can work to obtain the lists. So each of the health plans, as Anna also mentioned, has made has made a pathway for everybody to get this information and has identified contacts for if you need help getting this information. So we, if you're looking to kind of prioritize, we always recommend starting with your health plan with your largest patient attribution first, but certainly you can work on getting all of the lists in the beginning and go from there. Once you have the lists, you can start thinking about your documentation and billing workflows. Everybody will get a copy of these slides. There's some guidance on an earlier slide, and there's also good guidance in the toolkit that we make available with what you should be documenting as far as who did outreach, what did they say, what time, how long were they there, because there is the requirement that each counseling session reaches 3 minutes, that the patient was unvaccinated at the time of the call, etc. If you're thinking maybe an EHR template would be helpful for this, that kind of thing, I think would be really helpful to get going early as well. You can use some of the health plan lists come with contact information. We have found that it's probably best to start with the contact information that's in your own medical record to get in touch with the patients. And you can also, while you're in the EMR, you can take a look at the New York City Immunization Registry, which I know everybody is generally able to access, and see, confirm that this patient is still unvaccinated. So you can make sure you prioritize your time in calling the patients who truly need to get a vaccine. Anybody who received their COVID vaccine in New York City will be in CIR. And unlike for many vaccines where you can only look at adult information and transmit adult information with consent, for COVID and flu, it's open season. So you can see that information there and make sure that they are not vaccinated. And finally, you can conduct your outreach and then complete documentation and bill. As Anna mentioned, most of the arrangements are claims-based. So you're submitting claim by claim, just as you would for, submit an office visit, a claim for an office visit. You'll submit a claim for this 3 minutes of outreach, with the exception of those who have an alternate pathway to report these. And that is our recommended flow and some of the things that we've learned from the folks who've been rolling already. What's next? Is it questions next?
Yes, Matt, I think we are moving to questions now, and I've seen a few come through the Q&A section, but definitely encourage people to also put their questions in the chat. We have representatives from most of the health plans here, so I'm happy to respond to any questions. Before we move into that section, I just want to reinforce that the New York City REACH team is helping on the rollout of this program. So do not hesitate to reach out to the team if you are an FQHC or a primary care provider or has any type of have already a relationship with New York City REACH. And then for those of you who are part of hospital ambulatory care networks, Greater New York Hospital Association, the ambulatory care team is also supporting the rollout with education and technical assistance on the rollout. So please don't hesitate to reach out to either of the two organizations for help. I'll start getting into the questions. So Ali, will there be a recording emailed to all the participants along with the PowerPoint?
Yes, absolutely. We can send that out by the end of the week.
Great, thank you. The next question is, why can't any of the counseling activities be completed when the patient is in the office? This is a restriction that is actually coming from two different sources. One of them is that when a patient is already in the office, we have a vaccine advisory from the Commissioner of Health that instructs all the providers to counsel for vaccination every time an unvaccinated person is in front of you. The other reason is because we want to make sure that this service is a service that is being fully funded by the City of New York, and the health plans are providing this service fully in kind to the City of New York. So we need to make sure that if you are already in a visit with someone and you are billing Medicaid or Medicare for that visit, it may be Medicare or Medicaid's opinion that the counseling for vaccination should be part of the encounter. So we don't want to put providers in a position where there could be any suspicion of duplicate billing. So the cleanest way for us to make that happen is that if you are already providing a billable service, that like an E&M encounter, please, that is the encounter that you're gonna bill for, and we really appreciate if you do counseling in that encounter, but it cannot be billed to the VOCP program. At a different date, you can of course call that patient and remind them of your strong recommendation for vaccine, but not during a same visit that you are already billing Medicare for. Okay, do we have someone from Health First in attendance? We have a question about what is the distinction between place of service 2 and place of service 11?
Hi, this is Binta Patel. I'm from Health First and the Director of Strategic Planning at Health First. And I think you're taking this directly from our provider alert that we published. So place of service 2 and place of service 11, we essentially added these two places of service based off of the setting that the counseling occurs, whether it be whether it be a telemedicine, which would be place of service 02. And I think we added the place of service 11 for providers that are billing place of service 11. As Anna mentioned, the service has to be conducted outside of the visit. However, we're allowing both places of service when billing for the claim. Does that answer the question?
Office. 2 is telemedicine.
2 is telehealth and 11 is office.
And for all the other health plans that didn't specify the 2 specific places of service, you just choose the place of service that is the one that fits better your the circumstances, how you did the counseling. Thank you. So they're asking if office is okay as a place of service. And yes,
for the claim, yes, we're accepting place of service 11.
Yeah, we definitely, if someone popped in the office just to say hi and they got counseled and they didn't receive the other billable service, that's please do encourage them if that's the only service you're providing to them that day. There is another question about could we display the first page of health plan information, the codes, contacts, etc. Ali, can we go to that one? I think we need to go back to the table and just want to remind that we, in the chat, I put the NewYorkCityReach.org link. New York City Reach is updating these about weekly. So by the end of the week, you should have information about Centene and United added there. And that's information that we are keeping updated and it's in a public website. So feel free to click on it because that link is going to have the most updated information. We have a question about, are the scripts adaptable for Spanish-speaking patients? Yes, of course. Please adapt them in for Spanish speakers of any language, ASL. Just what's important to us is that the non-clinicians have all the information that they need to respond to patient questions in front of them. There is a question from Brian Buckley about what if we bill on a UB? Can one of our health plan colleagues address this question? Brian, maybe you can. So the question is, clarifying is, what if we are using UBS, not USPOS?
I think what
That's
they're
fine. The
trying to
same
ask.
thing.
Oh,
Sorry, go ahead.
sorry. I was just going to say, I'm curious if the question is related to Health First specifically, as they're calling out place of service for the encounter claims.
Yep. So this has been again from Health First. So we do accept providers. So we understand that the UB place of service that were mentioned before in our response would not apply to UB, but we are accepting providers that bill on a UB04. So I don't think that's explicitly stated in the alert. However, we are accepting if services are rendered and providers who bill on a UB04 submit a claim, they're also in scope for reimbursement for this service.
Would you say a rule of thumb could be to follow, at least for Health First, follow the convention you would do for a telehealth visit?
I think that's a good way to put it. Yes.
Thank you. And another question for Health First is, are we choosing the place of service where the provider is working from? Or where the consult is?
Where the services were rendered. So depending on where the services, where the counseling was rendered, that would be the place of service that would be applied on the claim.
And the same applies to all the other plans, just regular claims. I'll move to the Q&A now. Will the 5 to 11-year-olds be on the list? At this time, no. The list that you are receiving are going to be all 12 and older who are on Medicaid, CHIP, or Medicare Advantage plans. And that includes some pediatric practices are going to receive lists, but these are for the 12 and older. We are currently considering the 5 to 11 population, but the 5 to 11 population is going to be 100% unvaccinated. So we're waiting to see how it rolls out before making a decision about whether they would be included for the counseling program. But at this time, they're not. Does the designee need to be credentialed under the health plan in order to bill? So I'll put a bit more context because I don't know if the answer is going to vary by health plan. So the health plans are disseminating the list via the primary care assigned provider. Once the list reaches the primary care assigned provider, anyone in the team of that primary care assigned provider could be providing the service. So that's what I believe is the designee is what Gabriela means by designee. The question for the health plans is, does the designee have to be credentialed under the health plan in order to bill? And let's go plan by plan. So if we can go, let's start with AmeriCare. AmeriCare, do we have anyone on the line? Would the designee need to be credentialed in order to bill? Oh, maybe we don't have AmeriCare. What about United? I'm not being very lucky calling out plans. So I'll let each plan just, if you are on the line, respond to this question.
I think on it might be, I would guess that you could kind of treat it as if you're billing for a venipuncture, like you don't need to tell them who actually stuck the needle in the vein, and that if you can bill it completely under that patient's PCP and do not need to report who actually made the phone call. And I would say maybe if there is any exception to that, which I think probably there aren't many, maybe a health plan could speak up with an exception.
Thank you, Matt.
Yeah, this is David Ackerman from Health Plus. You know, since the city will only reimburse counseling sessions that are done by the provider who is matched to that patient, I don't think we can, I don't think there are any exceptions for us, whether, so no, we would not want to pay for things that fall outside of that because we won't be reimbursed for it.
Thank you, Dr. Ackerman. In your case, it would have to be a provider credentialed with the plan in the practice.
The provider credential, but the provider who that member was assigned to. I mean, if the provider is not credentialed, we wouldn't pay the claim anyway because it would. We don't pay claims for people who aren't credentialed.
So if you get anybody who gets a list for Dr. Johnson's patients from a health plan, the outreach to that patient should be billed under Dr. Johnson.
Yes.
Hi, this is Adam from Emblem Health. One of the ways that we decided to do this was to match the member or patient with their the tax ID that the provider usually bills under. So, for example, if patient A is usually matched with location A for where the member usually sees their provider, we allow for any provider or assistant, nurse, or whatnot to bill under that same TIN, and we will accept that claim as a potentially viable claim. Simply because we know that sometimes providers will not be available in the office, or another provider may be covering, or sometimes like an MP or another provider may be seeing that member that's paneled to a provider in their office. So we accept claims with TIN and member or patient match.
Thank you, Colin. So I think that one of the next steps is when you are not anticipating that the provider, that like if the primary care provider is not the one that is going to be doing the outreach or is not going to be the one submitting the claim, but you anticipate that is a colleague with a different NPI that is going to be the one submitting the claim within the same organization, please reach out to the plan to make sure that it is acceptable for them, that you use that approach. But if you are going to be using if you are going to be billing under the provider who received the list, then there shouldn't be any issue in terms of billing. The next question, do we have someone from Metroplus on the line?
Yes, I'm with Metroplus.
Great. There is a question for you. Can you expand on reimbursement for Metroplus capitation and how payment will differ for non-clinician and clinician?
I'm sorry, you were breaking up a little bit. Can you repeat the question one more time?
Yeah, Rosalind is asking, can you expand on reimbursement for Metroplus capitation and how payment will differ for non-clinician and for clinician?
So there's different CPT codes for clinician and non-clinician on the encounter template where they'll be submitting the outreach to the members when they've conducted the outreach.
And is there any difference if the provider is capitated or not capitated?
No, this does not affect whether they're capitated or not, as long as they're doing the phone call for the counseling, and that's the only service that's being rendered at that time. They will get a payment per member per counseling, depending on if it's a clinician or a non-clinician doing the phone call.
Thank you.
So if you look on the grid that you had up before with the CPT codes, there's a CPT code for clinician and a CPT code for non-clinician. So the 96160 is for clinicians and the 99429 is for non-clinicians.
Thank you. And Ali, can we go one slide back to display Metroplus codes? Thank you. The next question we have here. So a non-clinician can do the counseling, and we can bill under the provider codes and name as the provider will sign off on the note. I'm not sure if I'm following. If a non-clinician did the counseling, it can be billed under the provider using the Nonclinician Code. If it was a clinician doing the counseling, then it should be billed using the Clinician Code. So for example, the primary care provider could delegate to a nurse, a registered nurse, or could delegate to a pharmacist, or could delegate to a medical resident in the same practice. In those cases, the $50 rate can be billed. If the provider instead delegated to a community health worker or to a social worker or to someone else that is not a clinician, then in that case, even if the provider bills, it should bill the $25 rate. Do health plan colleagues have any additional guidance? Okay. So there is an additional question. I believe it applies to Health First as well. When plans are saying place of service 2 or 11, this refers to a 1500 form. When they are not saying a place of service, is it still a 1500?
I think this might be referring to the question earlier around the UB04s, providers that are billing on a UB claims template. So the place of service 2 and 11 is really tied to the CMS 1500 form. And then, providers that are billing on a UB where place of service is not one of the fields, I think that's the nature of the question. And we would be accepting both claim types for reimbursement of this service.
And if another question related is if we bill on a UB and a non-clinician provides the service, where would we add them if they do not have an NPI?
The billing should really be under, kind of as Matt had mentioned, under the PCP. For our members, members have an assigned PCP, and PCPs in the network have a panel. So the claim really should be billed under the member's assigned PCP, or the PCP if it's the services rendered by a covering provider, covering PCP, or a member of the staff that rolls up to a covering PCP, then that should be the name of the provider that's included in the claim.
A question from Francis. So the billing provider must be the assigned PCP?
It doesn't have to be, it could be the covering PCP, but it should be a PCP that that either is assigned to the member or for whoever, or the covering PCP that works with the assigned provider that rendered the services. But it has to be billed under the applicable PCP that's tied to that member.
Thank you. For any of the other plans, is the guidance different? So to summarize, the billing provider should be the PCP or another PCP in the same TIN, and then utilize the codes that are more relevant to who actually provided the outreach, be it a clinician or a non-clinician. The information about who provided the service would go in the documentation in the patient record, but the billing would go under the PCP. A question for Emblem. Is this exception only for this program? Because normally Emblem will deny for missing referral if a patient sees a different PCP.
So yes, normally we would, but again, we are, for these sets of claims for this specific CPT code, we are matching it with the member's provider's usual TIN and the member list. So again, all of those claims should be adjudicated correctly. If not, we will pen all the denied claims and do a manual review and adjudicate them as they come in.
Thank you. I'm not seeing any additional questions in the chat, but we'll give folks a couple more minutes to add additional questions or to paste questions that maybe went unanswered in the Q&A or in the chat section. And we will be happy to take them right now. Okay, I don't see any more questions. Oh yeah, now I see questions coming. So Frances really would like the PowerPoint and you will have it by the end of the week. A question from Vera Antonius. If a patient is on our roster but not followed by us, are we still able to bill? And Vera, can you, when you say our roster, do you mean a roster that you keep in your practice, or the list that the health plan send you of your patients who are eligible for these? Oh, the roster provided by the insurance. Okay, so if you basically, if a health plan is giving you names of people who are in your panel but are not followed by you, are you still able to bill?
No, if you received a member from our health plan, I'm speaking for Health Plus, and I would imagine, you know, for other laws and reasons, if you received a member on your roster that's not actually your member, you should disregard that member and then destroy the information, and we wouldn't expect you to cancel a member or patient that is not yours. You know, the intent and the purpose is that this is a member who trusts you, you're their provider, and that's, you know, how you're encouraging them. So we would advise against that and ask you not to do so. And please let us know if we send you members that are not yours.
What about in the case where a patient may be on a roster but has not ever engaged in an encounter with a provider, you know, somebody that they've reached out to and hasn't called them back? It's not that they got the wrong patient on their list, but that it's the right patient on their list who hasn't been able to be engaged in care thus far.
You know, we can't control for all eventualities. If they've chosen that provider as their PCP or they've been assigned, that's sufficient to our mind to have provided them that information to the provider. So we're not excluding people who've never had a visit.
Got it. So as long as the patient, as long as you are correctly the primary care provider assigned to that patient, you should proceed with the counseling. In the case that you are not the provider of that member is when it would be helpful to flag for the plan that you have received information about a member who's not in your panel. Okay, I don't see any more. Oh, if siblings are unvaccinated, can there be more than one claim? We have been thinking about these a lot. We are paying per patient, and in this case, it is 2 patients. However, you are not, unless you counsel the mom or one parent and then the other parent, and you counsel 2 different people, there is no point in repeating the script twice to the same person. So we would ask that if you know that they are siblings and you are counseling only one of the caregivers, then there is only one claim. But I think this is going to be kind of on the honor system. I don't know if any of the health plans have any way to, or any additional guidance for the cases of siblings. I guess a caveat that I would make is that if you have very different health conditions of the two siblings, and you need to have a whole different script and counseling for each of the two siblings, then use your medical judgment for that. But it's a tricky one, and it's one of those that we decided to just trust the providers to do what's the most ethical thing to do, and we will just trust you all.
And Anna, I'm assuming in that scenario that both of those members, the patients, are on the list. Both are on the list.
Yep. They would both be on the list. Okay, so just as a reminder, Ali, we can go to the slide with the New York City REACH contact information. Please, for any questions, do not hesitate to reach out to the New York City REACH. Also go to their website so that you know what is the email address that has been habilitated by each of the health plans to respond to questions from the providers. And I want to thank you very much for this hour with us and for the efforts that you are going to make or are already making to get the remaining almost 1 million of New Yorkers that are still unvaccinated and above age of 12 to get vaccinated. We have identified through the participating plans 1.3 million people that are eligible for counseling because they have been eligible for vaccination for a while and have not gotten vaccinated yet. So there has been, I think the city has done a lot, and the city, the providers, everyone has done a lot to try and get them vaccinated. And we are counting on a strong recommendation from you as their providers to really get them to take that next step in vaccination and get protected against COVID-19. So we really appreciate all the efforts that you are putting in place to really get them vaccinated. And for all of the pediatricians that are out there, please also help us with the 5 to 11. They're not going to be part of this program, at least for the time being, but we're eager to see them vaccinated as well. Yeah, and thank you to all the health plans who are doing this for free. And so really, really thankful for them and for all the manpower that they're putting to respond to questions from providers. Have a great rest of your afternoon.
Thank you.